Hey guys, this is the recording for Lecture 7 of the Respiratory Unit discussing chest and lung trauma as well as chest tube nursing care. We'll begin with chest trauma, and this can be described or categorized as either a non-penetrating chest injury or a penetrating chest injury. So non-penetrating injury would be something like a rib fracture or a pneumothorax or a contusion, a bruise. The penetrating chest injuries would be something like a gunshot wound or a stab wound. So the symptoms can vary, of course, dependent on the type of injury that is present. And, first we obviously would assess for any signs of just obvious external chest trauma. What do you see externally on the chest? And looking at, are they experiencing severe pain with breathing? Any signs of hypoxia, cyanosis going on? Do we see some immediate bruising that's developing, a hematoma developing anywhere? Is there asymmetrical chest movement with their breathing? Are they demonstrating any signs of shock, that weak, thready, tachycardic kind of a pulse, decreased blood pressure, a deviated trachea that could tell you that there's shifting of organs inside the thoracic cavity? A sucking chest wound is where there is an opening in the chest wall, so a penetrating chest injury, and air is moving in and out of the chest wound. So that can cause severe respiratory distress if that is present. Crepitus is a crackling sound that occurs when pressing on the skin, and it's caused by air accumulating under the skin, what we call subcutaneous emphysema. When you press on crepitus, it feels like you're pressing on Rice Krispies and they pop, pop, pop. It literally makes that kind of a sound and feel to it, pop, pop, pop. So crepitus is very interesting. It's a very interesting assessment that you could see. And then do they have any sputum that has any blood present that tells you that there's bleeding inside the lungs? Immediate care is aimed at stabilizing the patient and, assessing those ABCs. Do they have a patent airway? Are they breathing normally? What's their circulation like? If you see any obvious bleeding anywhere, applying pressure to that, getting an occlusive dressing over that site. If there is what we call a sucking chest wound, where there's an opening in the chest wall and air is moving in and out of the chest, then an appropriate first nursing action would be placing a vented dressing over that site, which is a 3-sided dressing. You tape only 3 sides of that, and that's going to then allow air to exit from that untaped section of the dressing. But then on inspiration, that dressing will seal over the opening in the chest, blocking air from entering back into the chest. And there's a picture on the next slide to illustrate that. Keeping their head elevated to help support their respiratory status, oxygen as needed. If there are any impaled objects present, something that is, a knife, some kind of a device, something sticking out of the chest, we do not remove those. Those stay in place. If it needs to be stabilized until the physician can address it and surgically remove that, you could even place some kind of a dressing around it and tape it to secure that so it doesn't get dislodged accidentally. Here's the vented dressing, or a 3-sided dressing that we were just discussing, where you take that and you tape it on 3 sides, place, cover over the open chest wound, and then on inspiration, that dressing seals over the opened wound, blocking air from entering into the chest or the thoracic cavity. But then on expiration, any trapped air inside the thoracic cavity in that pleural space is able to exit through that untaped side. Rib fractures are one of the most common types of chest trauma and injury that you see, thinking about motor vehicle accidents or any kind of a high impact sports injury, things like that. Rib fractures are very, very common. And they are extremely painful, very painful. Anyone who has experienced a rib fracture can relay that to healthcare providers, how painful that is. So you might notice that they breathe more shallow, they're splinting the area. That's fractured because it hurts so much. They don't want to take deep breaths. And we know that could lead to bigger issues as well, like a respiratory infection, pneumonia, and those complications. So pain management can be difficult. And this is just simply diagnosed by analyzing a chest x-ray, and you can see those fractures in the rib cage on the x-ray there. For treatment, the bones will heal on their own. We know that. It'll go through a healing process. It takes weeks, though, a minimum of 6 weeks usually for rib fractures to heal, if not longer. But to manage their pain, yes, they will need to have pain medication, but we don't want to over-medicate that suppresses their respiratory drive. But that pain really is quite a lot, and it can be challenging to control it. So sometimes they'll use nerve blocks, intercostal nerve blocks, and that provides some local pain relief at the site, and that will help also prevent those complications of the opioid narcotics. So that's something that can be utilized, and then just with also over-the-counter analgesics like Tylenol or ibuprofen. It is not recommended to splint or wrap the ribs with binders or anything like that while the rib fractures are healing, because that's just going to prevent them from taking deep breaths. It will cause the alveoli to collapse, and they'll develop atelectasis and pneumonia. So that is not recommended. If there are rib fractures present and there's broken segments, adjacent ribs that are broken in 2 points in each rib, causing this free floating rib segment, that can cause what we call flailed chest. And flailed chest, what you see is this paradoxical breathing where that flail segment goes in on inspiration and then out on expiration. And the problem with that is it decreases the amount of air that can be drawn into the lungs while breathing. Many times, people that have flailed chest and that paradoxical breathing going on are going to need to be intubated and supported on a ventilator for a period of time. So this picture illustrates the paradoxical breathing where that flail segment there will go in on inspiration and then out on expiration. And it's decreasing the lungs' ability, to draw in that air into the lungs, which will impair their gas exchange. There's a video that is posted under Lecture 7 in Canvas. It's a good illustration of paradoxical breathing with flailed chest. So be sure to check out that video link in Canvas. This x-ray here shows especially with trauma patients, that they can have multiple rib fractures, as you can see here, multiple areas. And it can be very challenging in managing their pain while those are healing. A pneumothorax, and it's a risk of developing a pneumothorax when there are rib fractures because that could puncture the lung. But with a pneumothorax, there is accumulation of air in the pleural space, causing either partial or complete collapse of the lung. There are different types or variations of pneumothorax that can be seen. First is open pneumothorax with a traumatic chest wound, allowing air to move in and out of the chest wall. That is what we call that sucking chest wound. That is going to cause the lung to collapse on the affected side. A tension pneumothorax is where air repeatedly enters the pleural space on inspiration and pressure rises in the chest cavity. The accumulating pressure causes the affected lung to collapse, and this also is commonly associated with some type of chest trauma or a punctured lung. So with a tension pneumothorax, the patient continues to breathe, pulling air into the injured lung, but the air escapes into the chest cavity instead of back out through the trachea and the mouth, leading to accumulation of air in the pleural space. Next is a spontaneous pneumothorax, not caused by injury or trauma. This is caused by small sacs of air, also called blebs, on the lung surface that rupture, and then that causes air to be drawn into the pleural space, and it cannot escape. These are often associated with interstitial lung disease, as well as severe emphysema. And then a hemothorax is accumulation of blood between the chest wall and the lung due to damaged blood vessels or lung tissue. When blood accumulates in the pleural space, it causes increased pressure around the lung and increases the risk of a pneumothorax, causing the lung to collapse down partially or completely. This picture illustrates an open pneumothorax where air is allowed to move in and out of the chest wall, as you can see here, on inspiration and expiration. That can cause the heart, the trachea, the esophagus, and all the blood vessels in the thoracic cavity to shift back and forth, and that's called a mediastinal flutter. As you can see here, it's illustrating how these organs can move back and forth. Symptoms of a tension pneumothorax: pain, and it can be a very sudden, sharp, pleuritic type pain, shortness of breath, very rapid, shallow breathing. You can see that they have an obvious air hunger going on. Cyanosis can be present, decreased or absent breath sounds on the affected side. A mediastinal or tracheal shift is where the trachea, the heart, esophagus, and those blood vessels will shift toward the unaffected side. This is considered a medical emergency because it affects the respiratory system and the cardiac system, and eventually can decrease cardiac output severely enough to lead to shock and death. Hypotension, because of the compression on the vena cava and decreasing the amount of blood flow that can return to the heart. And then, of course, shock symptoms, tachycardia, diaphoresis. So this picture is illustrating the mediastinal or tracheal shift toward the unaffected side with a tension pneumothorax. So here's the affected side. And this is actually with the open chest wound here that you can see. Okay, that they've got a dressing covering over that. But with that collapse of the lung, what you can see here is the shifting of the trachea toward the unaffected side. So for a tension pneumothorax, diagnosis can be quickly made based, of course, off symptoms, but also then doing a quick chest x-ray and be able to evaluate the collapse of the lung. And then treatment for this is getting a chest tube inserted. So the physician will be quickly preparing to do that, and you as the nurse can assist with that procedure. And chest tube will be placed somewhere between the second to fourth intercostal space to help evacuate the air in the pleural space. Pain control is a must. This is a very painful issue, and chest tubes are very uncomfortable as well. They can rub a lot of nerve endings that are in the thoracic cavity. So pain management is a must. Keeping the head elevated to support the respiratory system, help to re-expand the lung, providing oxygen as needed. Pleural effusion is basically accumulation of fluid in the pleural space. This is rarely an issue solely on its own. There is usually some kind of an underlying issue, like an infection or a disease process, cancer, something like that, that is causing fluid to accumulate in the pleural space. So the symptoms with this, of course, there can be adventitious breath sounds, diminished breath sounds, fever if there's infection present like pneumonia, and then the diagnosis is quickly made based off of a chest x-ray. As you can see on this chest x-ray here, so the red line that's labeled B, that's the width of the lung, but then the red line A is the fluid that pleural effusion that is sitting around the lung in the pleural space. So you can see next to it that the space that's just the air, that's the lung that's collapsed down, and that pleural effusion is all that white space, line A, filling the pleural via cavity there. So treatment for this is chest tube placement to drain the fluid, or they could do a thoracentesis if they don't need a chest tube kept in place. So thoracentesis is just a needle aspiration inserted, into the chest wall and in the pleural space, and they remove the fluid. But if they need a tube kept in for a period of time, then they would place a chest tube. Diuretics could also help remove some of that fluid. And then, the underlying issue, whatever's causing the problem, that needs to be treated as well. If it is an infection like pneumonia, they would need to be treated for that. If this is a chronic recurrent issue, some patients will have what's called intrapleural fibrolytic therapy. And that is where, when the chest tube is placed, nurses that are specially trained to do this, there are medications that can be instilled into the chest tube, which goes into the pleural space, and it will break up the bonds in that fluid and then make it easier for all of that effusion or that fluid to drain out. That's typically used for people who are having chronic recurrent pleural effusions, typically not for someone who's just a one-time event. Now, an empyema is where that fluid in the pleural space, in the pleural cavity, becomes infected and turns into a purulent or pus type of a drainage. And it gets kind of loculated, kind of turns into this walled off area in the pleural space, and can be really challenging to get that to drain out because it becomes kind of walled off like that in that infectious fluid. This is typically a complication of something like pneumonia or some kind of a trauma to the chest, or after thoracic surgery, infection could develop there in the pleural space. It can cause permanent scarring in the pleural space and cause it to become tight and restrictive. Treatment, they need to remove the infectious fluid, typically with chest tube placement. And the symptoms, commonly you're going to see pleurisy type symptoms where they have that pain with breathing in and out, and then adventitious lung sounds, symptoms of infection, the fever, elevated white count. But then the treatment is getting a chest tube placed to help drain that fluid. They can also do that intrapleural lytic therapy with this as well, where they instill the medication into the chest tube cavity, through the chest tube into the thoracic cavity, and that breaks up the infectious material, that purulent drainage, and then allows it to drain out from there back out to the chest tube. Antibiotics, and typically it'll be IV antibiotics that can then transition to PO antibiotics. There is a surgical procedure called a decortication. This is where they go in and surgically remove fibrous restrictive membranes around the lungs. And that's going to help improve their lung expansion, because that restrictive lining and that scarring that can happen around the lungs, that really can restrict their lung expansion. And so the point of that surgery is to help remove that scar tissue and those restrictive membranes to improve that lung expansion. Then there's also a procedure called a pleurodesis. This is help to prevent fluid accumulation around the lungs, used for patients with recurrent pleural effusions or empyemas. And what they do is go in and instill an irritant into the pleural space in order to create inflammation that causes the pleura to stick together, thereby permanently obliterating that space between the pleura, which prevents reaccumulation of fluid. When we say between the pleura, remember that the thoracic cavity is lined with the parietal pleura, and then the lungs are lined with the visceral pleura. So those two linings, in between there's a thin space that has just a small amount of fluid normally to allow the lungs, as we breathe in and out, just to move easily and gently along the lining of the thoracic cavity. But in that pleural space is where that fluid can accumulate too much, and that's where the effusion can happen, or the empyema, where that fluid becomes infected and it sits there in that pleural space. So with that pleurodesis, they are basically instilling a medication to cause some inflammation of that parietal and visceral pleura, and basically forcing them to now become adhered together to obliterate it, so no more fluid or infection can develop and accumulate in that space. There's a good video link posted in Canvas under Lecture 7 that illustrates how a pleurodesis is performed. Pleurisy or pleuritis is just inflammation of the pleural lining. Like we just saw, the parietal and visceral pleura is just inflammation of those linings that can cause a very sharp stabbing type of chest pain, typically a complication of an underlying respiratory disease or a respiratory infection. And they can also have a cough with it, a little bit of a increased temperature with that inflammation, adventitious breath sounds. A pleural friction rub could also be heard, which kind of sounds like leather rubbing together. It's kind of an interesting sound to hear. And then, the pain is typically pretty severe and abrupt on whichever side of the chest that they're having that the most inflammation. So diagnosis, on chest x-ray, they might see some of that inflammation there. Also just could be based off symptoms, just knowing that they had a recent respiratory illness. They might be able to determine that there's pleurisy going on, or they could do a different type of a scan. If there is any fluid that's developing because of it, a thoracentesis could be performed to help remove that fluid from the pleural space. So as we mentioned, a lot of the underlying causes are things that are either like an infectious illness, respiratory illness, or cancer, some kind of an underlying disease is the common cause. Treatment, NSAIDs can be beneficial in treating their pain. Heat application might be providing some relief for the patient, so that could be appropriate. If they're having a frequent cough, antitussives to treat that. And then, antibiotics if they think there is an infection that still hasn't cleared up yet. O2 as needed. If they need to drain any fluid, the thoracentesis or chest tube would be utilized for that if they are having signs of pleural effusion. Keeping the head elevated and our normal respiratory actions and interventions of the turn, cough, deep breathe to help mobilize secretions and remove any secretions out of the lungs. All right, so let's finish talking about chest tubes. And we've discussed chest tubes with these different disorders of the lung. And, now we'll kind of talk about how we manage these and what our nursing care is for chest tubes. The purpose of these is to reestablish negative pressure in the pleural space and also allow for any drainage of fluid that might be present in the pleural space. The pressure in the chest is normally less than atmospheric pressure, which allows air to move into the lungs with inspiration. So the point of the chest tube is to reestablish that negative pressure as well as drain fluid. The kind of a historical look at it, and we'll look at the mechanism behind chest tubes, but basically the tube, kind of the old school version here, the tube had to be kept underneath water, and that's what we call the water seal chamber. That water seal chamber is what maintains the negative pressure in the chest and keeps the lung, or allows the lung to reinflate or keeps it inflated. When working with chest tubes, we want to make sure that we're definitely when you're working with the tubing, if you're connecting like a new chest tube unit to the tubing or anything, keeping all that sterile, because we don't want any contamination that could, bacteria could find its way into the thoracic cavity. When you have a patient with a chest tube in place, it's important that they keep that below their chest level at all times. We don't want any fluid that drained out of the pleural space into the chest tube unit to go back into the chest. So closely monitor that with ambulation, make sure they're keeping that. And they do have little hooks on the top of them, the chest tube units, that you can just hang on a walker, and they just hang that, there, so they don't have to worry about holding it, or the nurse doesn't really have to hold it. They just hang it on the walker as they ambulate. Always make sure that we have, extra equipment available, any clamps that might be needed if something were to get dislodged, or a dressing that we could place over an area where a chest tube, gets tugged on or dislodged. If that were to happen, Vaseline gauze or petroleum gauze can also be used as well, just to keep a tight seal and airlock seal around the chest tube insertion site. Make sure all the connections are in place. There's nothing loose. Monitor for any kinks and loops in the chest tube drainage system. So to give kind of the mechanism behind how the chest tube works, this is on expiration here, okay, when there's air in the pleural space, as you can see right here. When you breathe out, when that chest tube is in place, that's going to allow that air from the pleural space to escape out and be vented out, okay? And the tube ends in at least 2 centimeters of water. That's providing that water seal here to prevent air from going back up into the pleural space, and then air vents out. On inspiration, that water seal level here in the chest tube unit, yes, it fluctuates upward towards the chest, but the air is stopped from entering the pleural space by that water seal. A small of air that was already in this unit does not move up into the chest cavity. And again, this is that water seal maintaining that negative pressure, allowing air to vent out and allowing that lung to reinflate. Now adding on the kind of newer units, and we'll look at the chest tube box that we use today, but kind of transitioning here, they have a section of the chest tube unit allows for drainage of fluid if there's any blood, if they're like a hemothorax, if there's just fluid from an effusion, or if there's empyema, there's that infectious fluid, that has a drainage area. So there's an area for that to drain. And then we have our water seal chamber here, maintaining that negative pressure in the thoracic cavity. And then lastly, this is the suction control area. If we need to provide additional suction to the thoracic cavity to reinflate the lung, if they have a pneumothorax and that lung is collapsed down, then we can apply additional suction, and typically it's -20 suction to help reinflate that lung. So that's the different systems here. We have the drainage unit, we have the water seal section, and then we have the additional suction control. So to transition now from what bottles used to be now to our modern day box chest tube unit. Okay, this is your collection chamber here. And then the air vents and drains here into the water seal chamber, that 2 centimeters of water, providing that, keeping that negative pressure in the chest, in the thoracic cavity. And then lastly, we have our suction control chamber here. Now this is a water seal system. They do have the chest tube systems that are dry seal systems, that instead of water here to apply that -20 suction, it is a dial that's on the chest tube unit. And you can choose the amount of suction. Most commonly ordered is -20. And then you just connect tubing here to the suction part of the chest tube unit, and that you connect that to the wall suction. And on the wall suction, you set it somewhere between 80 to 120, and that will then apply enough of that suction at the -20 setting that is on the chest tube unit. So things to be monitoring and looking at on the chest tube unit. Okay, the drainage, what kind of drainage is coming out, how much drainage, what we call the level of the chest tube, the total amount. And we compare that from the start of the shift to the end of the shift. If they were at 1,000 milliliters at the start of the shift and they end at 1,050, I know that the output for my shift was 50 milliliters, but the level change, at the end of my shift is at 1,050, and that's something that I would report to the next nurse, to the oncoming nurse. I need to make sure I'm assessing the water seal chamber here, looking for what we call tidling. So the water seal chamber should have a rise in water with inspiration, and it will drop with expiration. So the term to describe that, you can either hear this called tidling, oscillation, or fluctuation. They all mean the same thing. Now, tidling can stop at some point. What that could mean, the lung has maybe re-expanded. Maybe there's an obstruction in the tubing, like a kink in the tubing somewhere, or maybe there's a loop in the tubing preventing that airflow and preventing that tidling, or maybe the wall suction is not working. So those are all things to kind of investigate and look into. The bubbling that you see here in the water seal chamber can either be continuous or intermittent. Now, continuous bubbling in the water seal chamber can mean that there is a large air leak in the thoracic cavity or somewhere around the chest tube insertion site. And that's concerning because that air can escape up into the subcutaneous tissues of the chest. And that's where you would feel the crepitus, that grating, kind of popping feel whenever you palpate the chest. That also can worsen the respiratory symptoms and cause the lung to collapse down even further. If you assess a continuous bubbling in a water seal chamber, you would need to report that to the physician. That is of concern and needs to be reported. Now, intermittent bubbling in the water seal chamber is normal. With coughing or with a big deep breath in and out, it's not uncommon to see that. And they will have a kind of a range on them from 1 to 5 here in that water seal chamber. So a 1, an air leak of a 1, that intermittent bubbling is what we call an air leak. And so an air leak of a 1 is much smaller. That's a very small air leak compared to an air leak of a 5, where it's just a large, rolling bubble. That would mean that there's a large air leak, and that would need to be reported. Bubbling can eventually disappear in the water seal chamber once the lung has re-expanded, but it also can disappear if the tubing becomes occluded. So just always check the tubing, make sure it's not kinked or clamped, or any loops anywhere that are kind of kinking that tubing and preventing that normal movement of air. The only time we clamp tubing is if you have to change the chest tube unit you're replacing, because it will fill up. This drainage area here, it can fill up these 3 collection chambers. That can become full, and you can change it. So you can disconnect it here from the tubing from the patient to the box and replace it and put in place a new box. But that would be, where you would kink the tubing and just quickly, in a sterile manner, replace the one box and connect it to the tubing from the patient. Otherwise, we rarely ever connect the chest tube tubing, only if there is a physician's order to do that for some reason, because what can happen if you kink it, the chest tubing, that can cause a tension pneumothorax. As I mentioned, on the dry seal systems here, somewhere over here, you'll have a dial that you can select the amount of negative suction that would be applied to the chest tube unit. So all of this information is kind of re-described in a video that I posted in Canvas under Lecture 7. And it's a really good illustration of how to set up the chest tube unit, because the chest tube units will come with a pre-filled ampule of sterile water that you use to fill the water seal chamber. So it shows setting up the chest tube unit, and then the nursing care and how you kind of maintain that chest tube unit. But the important things to assess as the nurse, there's a good acronym here you can use, is STOP. So first, assess the site. Look at the dressing and see if there's any dry drainage, and it should be changed at least once per shift or as needed for excess drainage. And then you can palpate around the dressing and around the chest tube insertion site to see if there's any subcutaneous emphysema, that subcu air that occurs with an air leak. So you can palpate around the chest and see if you feel that. If you do, that would be something that would need to be reported to the physician. Check the tubing. Is it secured properly, taped securely to the chest to help prevent any dislodgement? Make sure there's no kinks or loops in the tubing. And then check the output. The chest tube box is never emptied. It's not like a JP drain that you empty at the end of the shift. But what we can do is mark on the box where the drainage level is at the end of the shift. So you need to check at the beginning of your shift to see where the level is, and then keep reassessing it every few hours throughout your shift. And then at the end, you can see where it ended up and subtract the difference. And that's your total output for the shift. And you can mark that level at the end of the shift on the chest tube box. You can do that. Some nurses will mark on there so they can see from one shift to the next, how much drainage that they're having out. Then we document the amount of chest tube output at the end of the shift, what the coca was, the color of it, and but again, we don't empty that box. It all stays contained. That drainage, that output stays contained within the chest tube box. Assess the patency and see if there is that fluctuation or titling or oscillation. They all mean the same thing. See if that is present. Check the setting on the suction, and you have to have orders for that. If there's orders for -20 suction, then you would connect the suction tubing from the chest tube box to the wall suction. If the suction is not ordered and it's ordered to be at water seal, then we don't apply additional suction. We just allow the chest tube box to maintain that negative pressure using that water seal chamber. So you need to look at your physician's orders and see if it's ordered to be, if the chest tube is supposed to be at water seal or if it's supposed to be applied additional suction. Check the water seal chamber for the bubbling, also known as an air leak. A small air leak, which is just that small intermittent bubbling, is normal with breathing in and out or coughing. But a very large air leak that is continuous and is a large amount of air bubbling that's going on in that water seal chamber is not normal, and that would need to be reported. And that tells you that they could start developing some of that subcutaneous air, and the lung could start collapsing back down. Now, what do you do if a chest tube is accidentally dislodged from a patient? If it's a surgical patient that has an opening in the lung and the pleural space, then just place an occlusive dressing over the insertion site. But if it's a trauma patient that you don't know if there is, a puncture in the lung or may only have an opening in the pleural space, then you would place that 3-sided vented dressing over the insertion site. And then what do you do if the tubing of the chest tube is accidentally dislodged from the drainage system? Well, you would place the end of the tubing that got disconnected from the chest tube box, the drainage system, place that into a bottle of sterile water to help vent the air to keep the lung inflated so it doesn't start collapsing down. And then you would need to get a new drainage system to connect the tubing to, provided that the tubing was kept sterile and wasn't, contaminated in the process. All right, so it would be a good time now this is the end of the lecture. This would be a good time to go into Canvas and watch that educational video on nursing care so you can see it illustrated. We described it here in the lecture, but now you can see it visually illustrated in that video. So check that out. And if you guys have any questions about lung trauma, chest trauma, or chest tube nursing care, please reach out to me and let me know. Okay, thanks guys. Talk to you later.